It's a pleasure to be part of this webinar, and I express my gratitude to Professor Kim Eman and the Uttarakhand Urology Society for inviting me. So I'm going to speak on the kidney transplantation in abnormal bladders. So ESRD due to dysfunctional lower urinary tract abnormalities accounts for about 50% of kidney transplant in the adults and about 20 to 30% in children. As the transplant has progressed over the last 5 to 6 decades, abnormal urinary bladder is found to be not a contraindication for kidney transplant. So, what is abnormal bladder? Basically, there are two important differentiations which we must have to look into it. One is the defunctionalized bladder, where because of oligonuria, the patients waiting for transplant, the bladder becomes defunctionalized. So, there is no particular definition for these defunctionalized bladders, but Arando et al. Has given a definition that the urine output less than 3 ml per day and the bladder disused for several years constitutes what is called as the defunctionalized bladder. So next group is the patients who have been diagnosed having neurogenic bladder, where the urodynamic characteristics suggest that the intravesical pressures are greater than 40 centimeters of water, thereby increasing the damage to the upper tract, and it impedes the urinary drainage into the bladder. So these are the basic two groups of patients who constitutes the abnormal bladders. So coming to etiology, basically the neuropathic conditions, bladder outlet obstruction in the pediatric as well as in the adult patients, mainly constituted with posturethral valve, the urethral stricture disease, vesiculated reflex, arcade voiding dysfunction syndromes, and diseases which affects the bladder, particularly tuberculosis in our country, interstitial cystitis, post-radiation, malignancy, and intravesical chemotherapeutic agents, as well as perivesicular scars induced by pelvic hematoma and prior ipsilateral kidney transplants. So these are the patients who constitutes under the umbrella of an abnormal urinary bladder. So it is always better to implant the ureter into the native bladder. So we need to assess the safety of the native bladder before kidney transplant. So what are the aspects which we need to look at it are the bladder capacity. The literature doesn't specify definite criteria. What is the minimal bladder capacity should be there in choosing such patients. Then we need to look at the history of previous urological diseases or previous as to rule out as the etiologies which has been discussed in the previous slide. So this is one of the most important things which will determine the success of the ureteric reimplantations and long-term graft function. And the other thing is that they look at the bladder wall morphology. So if the bladder was scarred and thick walled, then probably we might have to look for other alternative options. Then the role of bladder cycling. Bladder cycling is extensively practiced in many transplant centers, but the value of the pre-transplant assessment is not clearly defined in literature. Urinary flow rates. The Institute of Urology in London divided way back defined that the urinary flow rate should be at least 12 to 20 centimeters of water even before the pre-transplant, but there is no objective value defined in literature. And the most important thing is the urodynamic parameters. So if the leg point pressure is greater than 40 centimeters of water, then there's increased chance of damage to the transplanted kidney. So first, we need to rehabilitate the non-compliant bladders, the native bladder. We start with medical management using anticholinergics and intermittent self-catheterization plus or minus bladder cycling. If still at the end of this, if you have the bladder capacity doesn't exceed more than 100 ml or has a voiding pressure greater than 100 centimeter of water, then probably we have to go in for augmentation cystoplasty before considering transplant. So basically the goals of management will is the creation or facilitate normal drainage of urine from the kidney into the reservoir, which is created. Creation of a low pressure reservoir, which is capable of holding urine for a socially acceptable time, and volitional emptying of the reservoir with continence. It should be devoid of infection, and we need to perform minimal surgical procedures to achieve our outcome and thereby reducing the patient trauma. So, in the preoperative evaluation, it's very important to have a proper assessment of urologic diseases, particularly the diseases from childhood and the various kind of urological interventions that has been performed on these patients. Next, we look at the scars in the body, the presence of catheters and stomas, which may potentially interfere with the site of transplant, as well as the mode of urinary ureteric implantation. Then the basic urine analysis, culture from the voided urine or the bladder wash, and ultrasonogram to assess the post-void residual urine in these patients. So next two important investigation in this group of patients is the urodynamic study. And the basic purpose is to assess the capacity, compliance, the voiding phase, and the sphincteric function, and the voiding cystourethrogram. There are two schools of thought in these patients. The evaluation of these patients. Sometimes voiding urethropy has been overutilized, but the current consensus is that it's required in selected group of patients, particularly the patients with vesicular reflex, post-urethral valve patients, patients with a high residual urine volume, and patients with Stitcher disease. So, when you look at the principles of surgery in these patients, is that it's always better and implant the graft ureter into the native bladder. So, if the graft ureter is, if the bladder is found to be unsuitable, then probably we have to consider implanting in an augmented bladder or a continent diversion or into an entry conduit. Always try to preserve the native dilated ureter for future ureterocystoplasty if not considering a cystoplasty at the time of transplant or prior or after transplant. Clean intermittent self-catheterizations in these patients does not increase the risk of subsequent urinary tract infections. And low-dose antibiotic prophylaxis is recommended in these patients to reduce the risk of postoperative pyelonephritis. So let us look at the transplantation in special situations on augmented bladders. The timing for augmentation is contentious. Some group of transplant surgeons would want a transplant or augmentation before transplant because it avoids the complication of recurrent pyocystitis due to mucus protection, and then to prevent any damage to the vascular pedicle during transplant ureteral anastomosis. But there are other groups who believe that the augmentation can be done after transplant because we can it allows the healing, which can be compromised due to immunosuppression. So basically, if when the augmentation is done prior to transplant, it is timed about 6 to 8 weeks before transplant, and bladder cycling is performed in the interim to maintain the bladder volume and to remove the mucous secretions. So then, next segment of patients where the bladder is unsuitable for augmentation for ureteric implantation, they can be considered the form of an enteric incontinent or a continent diversions. The incontinent diversion is most commonly can be performed with a small bowel segment or in few cases with the large bowel segments as well. The goal of the diversion is to create a low pressure and a low volume reservoir. A few technical consideration in these patients is that the conduit is created about 6 to 8 weeks prior to transplant, and the renal allograft can be placed on the same side of the transplant or on the opposite side. On the same side, the conduit is placed retrocecally, and the graft is placed upside down to reduce the distance between the conduit and the graft ureter to facilitate urine flow and reduce the amount of absorption of the electrolytes. And the anastomosis performed end-to-side ureteroenteric anastomosis instead of searching for the proximal segment of the bowel which may be surrounded by dense lesions of previous surgery. So when you look at the entry continent divisions, this is required in patients who refuse to have urinary appliance. And hence, the reservoir is created prior to transplant, similar like an augmented cystoplasty. And there are a couple of case reports where the transplant ureter has been implanted in orthotopic neobladder. But the data is short-term data is only available, and the incidence of complications has been very high in this group of patients. So the other group is the patients who have a cutaneous ureterostomy preoperatively. In these patients, it is imperative to get a preoperative ureterography to note the presence of strictures, and when they are doing transplant, the native kidney nephrectomy is performed, and the graft uterus anastomosed to the proximal end of the native cutaneous ureterostomy, and thereby not disturbing the cutaneous ureterostomy at all. The other group of surgeons have suggested the graft ureter can be used as per se as a cutaneous ureterostomy, but it is associated with increasing amount of complications and usually not preferred. The advantage of cutaneous hysterostomy is that it eliminates bowel interposition and the complications associated with the bowel interposition as well. But the complications of cutaneous hysterostomy include graft pyelonephritis, stomal retraction, stenosis, and ureter anastomosis. The complications of the augmentation of a bowel segment includes recurrent pyelonephritis of the graft, and the incidence is very high in this group of patients requiring long-term antibiotics. The chance of urinary leakage, metabolic acidosis, particularly with the small bowel segments, calculus formation, vesicocutaneous fistula, bowel complications, parastomach hernia, stomal stenosis, perforation of the bladders due to increased pressure, and mycotic aneurysm and hemorrhage as well. In these patients, the postoperative care is very critical. The suprapubic catheters are left to drain the bladder for at least 2 weeks post-transplant, and antibiotic prophylaxis preferably continued for 6 to 12 months. In patients with asymptomatic bacteria, on the long term, doesn't require antibiotics except when patients demonstrate urine-splitting organisms in the urine, not to avoid steroid stone formation. Periodic blood gas estimation to detect and treat metabolic acidosis, not to protect the bone resorption. Mucus production need to be managed by frequent bladder washes and alkalizing therapies, vitamin B12 to treat megaloblastic anemia, and long-term surveillance, particularly to identify stone formation in the reservoir and development of malignancy in the augmented segment, though such risks are very, very low. So in summary, an abnormal bladder is no longer a contraindication for kidney transplantation. The goal is to assess the native bladder critically to assess the suitability for graft ureteric reimplantation, and the knowledge of the abnormal bladders will help in providing a successful transplant outcome. Thank you.